I want to welcome everybody to our NAMI Davidson County education session titled Understanding Psychiatric Medications with Dr. Joseph Pandit. Joseph is a great friend of NAMI. He has been with us several times in my 3 years, and I know he goes back farther with Robin and our agency. But I want to, with no further ado, I want to start our program tonight. If you have any questions, feel free to ask them in the chat or at an appropriate time during Dr. Pandit's presentation. If everyone could mute themselves during the presentation unless they're speaking, that would help with any background noise with our recording. So without any further ado, I'm going to turn this over to Dr. Joseph Pandit.
Thank you very much, Don. And I always appreciate you coordinating this, and I want to thank everyone for taking some time out of your evening to join. I was sharing with Don earlier, I'm still at the office. I work at an office here in Brentwood. I currently work for Monogram Health. So I don't know if a cleaning crew might come surprise me at some point and open the door. So if you see me get startled, that's who's coming in. And I'm also sorry that maybe the lighting isn't as great in here. I had to do some adjustment. I currently have 4 monitors, and this is a shared office that I stepped into. My office is elsewhere, but it wasn't. It's kind of out in the open, so I was a little concerned in case somebody's bringing a vacuum through. So I wanted to make sure I had some privacy and some quiet. So also, if you notice, and some of you may be on your phone, but for those who can, I want to make sure you're able to access this chat function. So when you're in Zoom, you may see at the bottom of your screen, at least it is with mine, you may see a little bubble, looks like a speaking bubble that says chat, and it should open up another window. I've put a message in there. It says, "Hi, everyone. Thanks for joining this evening. Feel free to ask questions here in the chat. I will do my best to answer at some point this evening." You may also see part of that pop-up box that shows who you're sending that message to. So currently, I have sent that message to everyone. Anyone else can respond to that. But if you click that where it says everyone, you can, if you wanted to, select Don specifically, and you can send a private message to him. So if you don't feel comfortable asking a question, within the chat where everyone sees it, then you can by all means send that to Don, and then he can let me know about it. If based on time, I believe we will be ending, at 8 o'clock or shortly prior. Don, I don't know if you had any other kind of closing and you wanted me done. It's like 7:45 or earlier, but I will try to end with enough time to answer questions. I'll also, I'm open to answering something in the moment. So while we're discussing it and you bring something up that is pertinent to perhaps the slide or what I'm discussing in that moment, please feel free to jump in. But if I'm discussing in the moment bipolar, let's try to keep on track and not throw me into ADHD all of a sudden. So, if there's something in that you feel you want asked before you forget it, please type it into the chat and either to the group or to Don, and I will do my best to address it. Like he said, I'll also be sending a copy of this presentation to Don for him to email out to the group. I do keep a slide at the end where I can type in some of these questions and answer. So there may be the situation where tonight we run out of time. There were 10 questions in the chat and I could only answer 5 tonight. I will also respond to those questions within the slides. And that way, Don, when he sends it out, you can see those responses. Okay. Does that make sense for everybody?
Yes, it does.
So just for background, for me really quickly, I've been a pharmacist now for about 15 years. Prior to that, I was a child and family counselor. Some of you may be familiar with Monogram. I work at Monogram now. It's the end of the day. You have to excuse me. I worked for youth villages for a few years and then transitioned to Omnivisions. So we did work with children who were in state's custody with DCS, all manner of issues stemming from a home life where they were placed in the custody, be it foster care, residential, adoption services, etc. It really got me interested in behavioral health. I'd always had a medical interest. Thought I might go to medical school at one point, and then ended up going to add on some psychology major to my pre-med work, where I then, like I said, worked at Omnivisions and youth villages. And after about 7 years of that, I just completely changed careers from that social work counseling aspect, where I then went to pharmacy school. I've had a lot of work, we call it float work or PRN. I was kind of the substitute teacher at Kroger for a number of years, just part-time. But my primary practice for about a decade was working with Skyline Madison campus. And some of you may be familiar with it, some you may not, but it is one of HCA's psychiatric facilities in the Middle Tennessee area. You may be familiar with Parthenon Pavilion, attached to Centennial. Skyline Madison campus is a satellite facility, of course, in Madison, which is associated with Skyline Medical Center, the main facility. They also have a newer facility, about 3 years old, in Columbia, Tennessee, called Pinewood Springs. Of course, there's Vanderbilt. There is Middle Tennessee Mental Health Institute, Trust Point. Of course, there's more facilities opening up. And at the same time, a dire lack of support and resources, I think, for communities and when it comes to behavioral health. Of course, there's the outpatient, Centerstone, Mental Health Co-op, et cetera. And then, of course, we have tremendous organizations like NAMI, who support on a community level within Nashville and Tennessee and nationwide. And then, the resources we need are often in short supply, and the good people that work with organizations like NAMI also in short supply. But I think ultimately is getting the word out, reducing the stigma of dealing with issues in regards to behavioral health, because it impacts virtually everyone, whether we want to admit it or not. And I know you've heard it as you come through these courses. I think they're still weekly, Don, or unless things have changed. But we see that we need help, we need answers, and we need questions asked. And so that's why I'm grateful to be in a presentation like this, because I can't do what I have done and learned without hearing directly from families and patients and things like that. I've been now at Monogram Health for the last 2 years. We are a company who focuses primarily on patients with chronic kidney disease. So I really changed the format of the patient population I was working with. I was in an inpatient setting, working with everyone from adolescent to a geriatric population, substance use disorder across the board, military for quite some time, patients with schizophrenia, bipolar disorder, mood disorders, suicidal attempts and ideations. But there's a lot of medical issues that go on. So, patients that might come in for depression, when we do the lab work, we're diagnosing with diabetes for their first time hearing about it. We're treating infection, we're treating asthma, we're treating, patients that have AFib and are on anticoagulation and things like that. So they brought me on board to Monogram to address, I'm sure some of you have heard that term, the Venn diagram. You see where there's circles and how do they overlap somewhere. There's a tremendous overlap for patients that have chronic kidney disease and behavioral health diagnoses. When we talk about maybe a chicken or the egg scenario, where has someone had a lifelong or chronic depression or anxiety disorder that led them to have worse outcomes? They're so depressed and anxious, they don't go to their doctor's appointments. They are not taking their medications. So we look at diabetes and hypertension primarily, that maybe go unaddressed, untreated. They're, again, not taking care of themselves, that then advance to a kidney disease, now requiring dialysis. Or are they getting some diagnosis of a very risky diagnosis like chronic kidney disease that now leads to anxiety disorder? They're worried about the cost of it, all the doctor's appointments, all the new medications they're going to take. So they brought me on board to address a behavioral health population that have what we call polychronic disorder. And I'm seeing a lot of value in that because we have patients with schizophrenia that have, this disorder. A patient I was reviewing today and working on has had a lifelong bipolar disorder that's on dialysis. And she gets into her depressed stage and starts skipping her dialysis treatments and ends up in the hospital. So we see, sometimes if we can help treat one aspect of her health, like, mental health, her access to medications, getting her to a doctor's office, we may reduce her suicidal thinking, which leads her to skip her dialysis treatments and end up in the ER. And she's only 45 years old. She's not one of our more aged Medicare patients who are 78 or 90. So I'm going to move on now with that, background being discussed and kind of go into what we'll talk about tonight. And I'm realizing just now I had not shared this screen. Am I sharing it? I am not. So let's go on here. I thought I was and I wasn't. Let's go to share. So please let me know if you can or cannot. Does it look like I'm sharing anything?
Everything looks good.
All right. You're seeing the main slide. Is that correct?
Correct.
Power of pills. Can you see my mouse pointer?
Yes, we can.
Someone,
Yes.
I think, Sarah, okay, you've muted your mic. That's good. Sarah, if you're just joining us, nice to have you on board. If you have any questions, you can add it to the chat. I don't know if anyone else has jumped on, but we'll go ahead and get going. So we're going to talk very briefly about some of these things, just because I want some completeness here. Let's talk about some of the background of mental health, impact on the family. And honestly, I don't really have to talk about the impact on the family. You guys could probably lecture about that all day long. Briefly discuss pharmacology, but then we're going to go into some of the drug therapies, and then talk about maybe barriers to therapy, which I think is what a lot of you are here for, because perhaps you've dealt with these issues with your own families or in your own, personal regimens. I always throw out, I am not a paid representative. So if I discuss a medication, perhaps more at length, I don't work for any drug companies. I don't do talks for any pharmaceutical companies, teaching doctors and pharmacists and otherwise about medication. Or I'm not a part of any marketing group. I'm currently a clinical pharmacist at Monogram Health. So this data is from 2022 from the CDC. And actually, these are some of the same numbers that we've seen, for the past decade or more. But I did update this from 2022 data. About 1 out of 4 Americans takes a psychotropic medication. And when I say psychotropic medication, I'm talking about the entire spectrum of mood stabilizers for depression. Those medications we might use in bipolar disorder, anxiety, schizophrenia. Some of those we might use in symptomatic relief for perhaps ADHD, personality disorders, etc. But 1 out of 4 Americans took a psychotropic. And I want you to also think about how many more Americans are not being treated. They have an untreated behavioral health, perhaps a diagnosis. Maybe it's something that is causing despair in their daily life that doesn't necessarily need a medication. But we know there's a lot of untreated individuals. But the data is showing 1 out of 4 Americans is taking a psych med. We have seen, like I said, I grabbed this from CDC. We don't know all the changes that are going to come out of COVID. A worldwide pandemic. We know that we've seen trend upwards in reports of substance use disorders, domestic violence, between spouses and significant others, adolescent violence as well. The idea of school-age children being forced to, do their schooling and continue and even graduate via Zoom. We know that socialization has changed in those kind of situations. But 28 states that were capturing some of this data that then reported to the CDC, so half of the U.S. has seen, and that's a pretty wide range, but a 10 to 50% rise in prescriptions since COVID. So then the question is, are there actually more illnesses Are people seeking care more appropriately? Of the medications used, antidepressants are the most used. And as we get into some discussion on medications, then you will see that antidepressants aren't solely used for depression. And I want to make sure I'm pulling my watch off here so I can track the time. Because as Don and Karen probably know, I get to talking and I want to make sure I'm able to provide the pertinent information you guys came here for. But impact to families, we know. These people can get on our nerves. Our loved ones, they can be attention seeking at times, perhaps frequent hospitalizations. It causes isolation. They withdraw from relationships. Symptoms can cause poor functioning for our children at a critical developmental time. How are they functioning not only at home, but in school, their extracurricular activities, within friend groups, within adults. Again, difficulty in relationship, work life, as well as a general sense of well-being. We talk about not only sick time, when patients miss or leave work for themselves or others, but we talk about those times when patients may have sickness, and it's not just things like the flu. We're here talking about behavioral health. They're depressed, they're anxious, but they actually go to work. They can't afford to miss time. They've run out of PTO and all their sick days. So they're going to work, but not performing at their best because of, other thoughts going on. Maybe they're having psychosis and they're having voices talk to them. They're feeling suicidal or anxious. All manner of symptoms they're experiencing. But we know that they have challenges, as we discussed earlier, finding and utilizing community resources, and their families, may feel isolated and very alone. As impact on healthcare, the expectation is, and this was from a pediatric journal, by 2020 to 2030, it's estimated that at least 40% of patient visits, so I think we're adolescents here, a pediatrician, will involve a long-term chronic disease management of physical and behavioral conditions. So the question again from earlier, are we seeking care more appropriately? Are we on too many medications? I think it's a mix. I think there are times where we could very objectively say we've put someone on a medication that probably didn't need it. We were looking to treat these symptoms, and instead of getting to an underlying cause, we're just slapping a Band-Aid on it by giving them a pill. But I also think that as programs like NAMI, people like yourselves get educated, through presentations like this or the classes that you go to, exposure to your own family members, I think some of that stigma reduces and people seek care more appropriately. I think we have better screening tools to assess when a patient may actually have something beyond what maybe decades ago would get largely ignored. I can tell you when I used to work with the military unit, I had family members who would kind of roll their eyes when they heard I worked with soldiers. These were active military. Well, back in my day when I was in the Army, soldiers weren't put on psych meds. It was like, I think about my grandfather, it was like, well, they didn't have pills around. He wasn't, didn't feel comfortable talking about some of his PTSD. You know what he did? He drank too much. He laid hands on my grandmother. So, it was dealt with probably inappropriately. So I think we have better screening tools. We very clearly have better options for medications, as well as any number of combinations with psychotherapy, seeing the psychiatrist, getting on medications. And so I think that's a larger piece of it. So 1 out of 4 Americans on a psych med, I think it's within good reason, and we may see that number change to 1 out of 3 as we're able to diagnose better. One thing I want to get across tonight is the purpose of medications, just in general. They are there to treat an acute illness. Think about some kind of sinus infection and you go into a minute clinic or one of those type of rapid clinics where you get seen by a nurse practitioner. Maybe you set up an appointment with your PCP because they can get you in pretty quickly. We're here to treat an acute illness, right? They're going to get on their laptop and send a prescription over to your pharmacy and have it filled, hopefully pretty quickly. But we also look at preventing future illness. That's why some of you might be on a cholesterol medication. You might take aspirin once a day because we are preventing something from happening. That is, say, a heart attack or a stroke down the road. Some of these psychiatric medications we use, they're not curing anything. They are preventing a relapse of sorts, like another trip to the emergency room. It may never stop the hearing of voices and seeing of things, and they may always have some level of anxiety, but what is it doing to their quality of life? Are we able to provide some level of maintenance to where those issues, are more prolonged when they have, say, a manic episode or a depressive phase? We talk about pharmacology, okay? Pharmacology is a very broad word. If we look at the math aspect of pharmacokinetics, that is, what does your body do to the drug? Okay, we think about things like the kidney, the liver, the bloodstream, the heart, the stomach, the gut, meaning your intestine. What is all of that doing to the drug? We think about absorption, distribution, metabolism, excretion. I'm not going to go into details about this, but drug design takes all of these things into account. Think about where a drug absorbs. Most of you would say in the stomach, right? Well, what about a cream or a lotion? What about a nasal spray? What about a suppository? What about an injection? Where are these drugs being absorbed? In the same thought, where does it go? Where is it distributed? So most of the medications we think of that are orally are going to be swallowed in the mouth, into the stomach. They're going to break down a little bit, and then they're going to go into the intestines where they're absorbed into the bloodstream. Okay? And at that point, does it remain in the blood or will it get into fatty tissues? We talk about terms like lipid, where then it can enter the central nervous system like the brain. We think about pain medications that can enter, perhaps not only the brain and sensations of pain, medications that might enter that spinal area, in reduction of pain symptoms. When we think about metabolism, it's not just, eating foods and gaining weight, slow metabolism or rapid metabolism. We think about the liver in this situation. And when it comes to excretion or elimination, we might think about the kidneys, okay? So this is a very simple chart. It might look complex at first glance. This graph is, we talk about pharmacy 101 and what happens when you take a medication. So if we think about the bottom corner here, and so this bottom line is the passage of time. This line that goes up is concentration. Think about the drug level, okay? So simply put, if I have a headache and I want to take Tylenol for my headache, right? And you read the label and it says, take 1 to 2 tablets every 4 to 6 hours as needed for pain or fever, right? So if I haven't taken a Tylenol ever, or I took it 3 months ago, there's none in my body. And that's this bottom left corner, okay? There's 0 drug in my body. And as soon as I take 2 tablets and it starts to break down in my stomach, the drug level of that Tylenol begins to increase. But it doesn't increase until eternity. At some point, my body has broken it down and it begins to leave my body. Does that make sense for everyone? And so we see that level rise and then drop again. Some of you may be aware of certain medications where we actually draw blood and take a drug level reading, like Depakote, valproate, valproic acid, or lithium, or maybe Tegretol, which is carbamazepine. We look at drug levels, and it's reading that, the snapshot in time, what is the drug level in the body currently. This dotted line that goes across is what we call the MEC, or the minimum effective concentration. Fancy word. What it means is I have to get enough drug in my body and cross that dotted line for it to work. I think we all understand that. If I have a headache, I'm not going to take a little, knife out of the kitchen drawer and cut off a little piece of it and take it and expect it to work. The label says take 1 to 2 tablets. It didn't say, take 1 little pinch of Tylenol. And I get that some people are reserved and they feel like, I don't like medication, the less the better. But we know from the manufacturer, you have to take a certain amount for it to work. But we also know this is what we call the maximum toxic concentration. We do not want to take 20 Tylenol when we have a headache because we know that's too much. It's toxic. It may not kill you, but it might cause liver damage. This is also an area where we are more likely to see side effects. We also know, think about Benadryl, right? 25 milligram little capsule you get at the pharmacy. You take it for your allergies. Some people might take it for sleep. You take 25 milligrams, right? And we know that's the minimum effective concentration, the minimum effective drug level to treat those symptoms for allergy. But we also know I might have side effects at that level. So we wouldn't necessarily call it toxic per se, but this middle section here between these dotted lines are where side effects can happen to anybody. Some people might take Benadryl, 25 milligrams, and experience nothing until they're maybe around here taking 50 milligrams. And that's also within the therapeutic range of a dose. Sometimes we'll see on that label, you can take 1 to 2 tablets of Benadryl, 25 milligrams each for your dose. The 25 to 50 milligrams is an appropriate dose, but you might experience side effects at the lower dose. If anybody has any questions about that, we'll keep moving. I will also mention, for aspect of the passage of time, we know that for those daily meds, for those twice daily meds, for those chronic everyday medications, you don't want to fall below that dotted line. When patients are skipping dosing, they are falling below the dotted line where it's not working. Okay, that's where we talk about things like adherence or compliance to the prescribed directions, because if I start missing doses, my drug level falls and it's here. We also know the math, that is the drug manufacturer knows the math of how it's being broken down and eliminated. It's like, okay, you take a dose, we know it lasts in the body for 24 hours, right? Before it's falling below this line. So that's why we want to dose it every 24 hours. So it's not ever falling below this dotted line. It's staying up here somewhere. We want to see that kind of flat line where it's in the therapeutic range. So we go beyond the kinetics aspect and talk about the dynamics. That is, we talk about what the body's doing to the drug, absorbing, metabolizing, eliminating. But what is the drug doing to the body? And we use fancy language in pharmacy and medical world, like the mechanism of action. What are the indications, adverse effects, and interaction? Well, the mechanism gets really down nitty-gritty on a molecular level. And I see Robin's face pop up. But Robin, we're glad you're here. I don't know if her microphone's on or not, but I'll keep going here. The mechanism of action, we think about SSRIs, selective serotonin reuptake inhibitors. Some of you may have heard of medications like a beta blocker. What's it blocking? And the correct answer is beta. Well, beta what? It's part of the beta adrenergic system where, simply put, you are reducing the impact of epinephrine or adrenaline in the body, or norepinephrine more specifically. So I can use a beta blocker to reduce the effect of epinephrine and norepinephrine to reduce my heart rate. Well, why would I want to do that? I might use it for blood pressure or heart failure and things like that. So that's the mechanism of action. An indication would be what the drug is for. Okay, what's its purpose? Adverse effect, those are side effects. Some are mild, some will kill you. And these are things that we have to watch out for. Interactions, we think about drug-drug interactions. Don't take this drug with that drug. We talk about drug disease interactions. Don't take ibuprofen if you have chronic kidney disease. We'll talk about maybe drug and food interactions. Avoid taking this cholesterol medication with grapefruit juice because it can impact, liver function and how it breaks down those statins. So if at any point you guys are opening maybe a manufacturer's pill bottle, not necessarily that amber vial you get from the pharmacy, but if you have a manufacturer's bottle or package, there's that little bitty square package insert, and it's got some of that rubber cement on it, and you can peel it open and open it up, and it looks like a road atlas that you will never, ever in a million years fold back up the same way how it came out of the bottle. And it's in super tiny print. And if you are ever having insomnia and difficulty sleeping, I suggest reading a package insert because it will bore you to sleep immediately. But you will also see a table of contents, and it will outline where in that big roadmap, of this package insert, it'll show you mechanism of action, indications, adverse effects, interactions. And it'll give all kinds of information. At the very end of it, it will show you the data, and where if you wanted to kind of nerd out like I would, if you want to look up the source of this material and the research, you can kind of go into it. But it does have some interesting information if you are ever so. I mentioned these earlier, this idea of psychotropic medication. The thing is, they have been labeled, from ages ago: antidepressant, mood stabilizer, antipsychotic, anxiolytic for anxiety, stimulants generally for ADHD, sedatives for sleep disorder. But you know what? Oftentimes we interchange these words. We might call an antidepressant a mood stabilizer. We can use antipsychotics classically for schizophrenia, but some are approved for, guess what? Depression. We might use a mood stabilizer to treat, some chronic anxiety. So I don't want you to get so caught up in this. This is still a way, though, in the medical world that we generalize some of those subclasses based on that mechanism of action. Okay? There's some theories about why people have a psychiatric illness, that we can diagnose. We think about genetics. We know there's a large correlation in a genetic aspect. Say, psychotic disorders or schizophrenia. If you have an immediate relative with it, there's a 50% increased chance of it being passed on to offspring. We think about neurodevelopment, drugs or infection, things that are occurring during pregnancy. Families are being alerted and treated for certain. We want to avoid deficiencies like folate deficiency. We think about no smoking and no drinking. What happens if that occurs during pregnancy? The possibility for infection, not only during pregnancy. We think about infectious disorders, during childhood and adulthood, which might, through a fever type scenario, might cause a mental illness or some sort of brain damage. And all of this, we think about the nature aspect. What about a psychosocial nurture aspect? What are we thinking about with the upbringing in the home, socialization or lack of? All of these, are often theory. We can see correlation again with research, but ultimately sometimes we don't know. Again, now theories on psychotropics. We think about neurotransmitters. A monoamine, again, is a nerdy term for the molecule referring to like an amino portion of a molecule. But I learned this mnemonic in school of SAND. These are some of your big ones: serotonin, acetylcholine, norepinephrine, and dopamine. These are also neurotransmitters that you're probably very familiar with. This is a depiction of how serotonin might work in the body. We think about nerves and nerve endings. So we have one nerve talking to another one, and then you have this space between the nerves called a synapse or synaptic cleft. And there are activities and functions that go on in the body where, say, for example, in this situation, a depressed mood, and the body thinks it needs the benefit of more serotonin activity and some of these monoamines. So it has these storage warehouses where the body thinks I need to release some, and it releases serotonin across this gap where it plugs in like Tetris into a receptor, okay? At this point, when it's crossing this gap, there are other chemicals that they're not alive, so don't mistake what my language is here, but they eat the serotonin. That is, they might metabolize it, okay? When serotonin makes it across, and I'm sure Don and Karen and Robin have heard me use the description of like Animal Planet, when a gazelle or some animal is out in the Serengeti or the savannah, and they're crossing this river, right? They're going through the water, because there's the nice lush green grass on either side and they want to eat it. But there's crocodiles in the middle, right? So these are your nice, pretty gazelles. They're leaping and everything across this big river. And you have these chemicals like COMT and MAO that want to munch on this serotonin like a crocodile. And then they get to make it across to the lush green grass and eat. But in this scenario, sometimes the body says, okay, we've had enough serotonin, and it rings a bell. And so it will displace itself from the receptor and go back into storage for next time. Okay. This is how most of our antidepressants work. And so we see drugs that block, that is, they muzzle the crocodile, the COMT. We see drugs like you may have heard of the MAO inhibitors, right, that also are muzzling this chemical, which allows serotonin to make it across safely. We also think about medications like SSRIs or some of the SNRIs. So think about not only serotonin, but maybe norepinephrine coming across this gap to plug in. SSRIs and SNRIs, they prevent that bell alarm from ringing. It allows serotonin to stay plugged in for a longer amount of time. It's a reuptake inhibitor. Okay? When I discuss some of the purpose of medications, I again want to hammer in the point, they do not cure. And this is a misbelief, perhaps is the best way to describe it, by patients of all types for all medical diagnoses. They do not cure anything. If I'm taking a blood pressure medication and I go see my doctor, or I have one of those home cuffs and I'm logging it from my doctor like they asked, and my blood pressure is better, I'm not cured because I've been taking this beta blocker or this lisinopril or whatever medication I'm taking. That doesn't tell me I should stop taking. My blood pressure is improved and will stay improved as long as I take my medication. But certain medications might come with side effects, other barriers that want them to stop taking. And what we do know with medications, especially when it comes to psychotropics, it can relieve or decrease symptoms. They may prevent the return of symptoms. And oftentimes we have to understand they are not intended to be used as sole treatment. One other piece that patients need to understand is that it may take weeks to see the benefit. So for depression, we use very fancy terms like affective, mood components. Behavioral, it may cause them to act a certain way. Somatic and cognitive, we think about some of the ways that our brain, can affect behavioral pieces. MDD is a term used for major depressive disorder. Dysphoria is a term for low mood, but may not meet very specific criteria for a diagnosis of MDD. This is older data now. Some of you may remember, I think it was Time magazine that came out with Prozac Nation on the cover of one of their issues. I mean, when it came out, in the late 80s, early 90s, we're talking nearly 70 million people that were started on an SSRI. We had medication previously, but when this new class came out, they had reduced side effects that had made patients quit all the old stuff previously and kind of went with an uncontrolled mood disorder, untreated depression, because the doctor's saying, well, this is basically all we have to work with and prescribe a med, but it caused so many side effects that patients quit taking their meds. When SSRIs came out, they had a much better side effect profile. So now patients could breathe a sigh of relief because now there was a medication available that they could tolerate. All antidepressants carry a black box warning. So virtually every medication known to man is going to have a side effect. Okay. A black box warning, though, is a flashing neon sign that says something drastically wrong and bad can happen if you take this drug. Some of you may have heard of a drug called ciprofloxacin. It is an antibiotic frequently used for infections of varying types. We see it a lot with UTIs, maybe skin infections. It has a black box warning that virtually says your tendons could rupture. your Achilles tendon might detach from your heel bone. We might see it in other aspects. Can you imagine that you're being given one of the most common antibiotics known in America, and you see this warning that basically says your tendons could explode? Now, they're not going to pop and smoke come out of your skin or anything like that, but they could be very problematic with a very, very tiny incidence rate. There is a black box warning for all antidepressants, an increased risk of suicidal thinking in children up to adults to the age of 24. We have no method to determine the exact reason for this. I can't draw labs. I can't do an X-ray or an MRI or a CT scan to see what was actually happening if someone was thinking about or completed a suicidal act. What we think is theory, that when you take a medication like an antidepressant, if we think about the qualities and symptoms of depression, of low mood, low energy, oftentimes suicidal thinking, sometimes not, decreased appetite, increased appetite, changes in sleep patterns, people have come to their wits' end. Oftentimes there are environmental, psychosocial factors that are impacting that, abusive relationship, housing insecurity, food insecurity, financial problems, any number of things. I hate my job, COVID, who's in the White House this year? I mean, any number of things can impact patients' mood. And when it becomes very chronic in nature, medication may be vital to their survival. We look at an aspect of anhedonia and energy specific. When you take an antidepressant, sometimes one of the first benefits we see when starting a medication is an increase in energy. Patients may have poor hygiene. They're not able to get out of bed, interact perhaps with, members of the family. But maybe some of the bad things environmentally are still there. So the presumption possibly, I'm throwing that out there, possibly, because again, we have no proof. But the idea is maybe when they get a boost of energy, some suicidal thoughts they've been happening, they're now able to act on them. So it doesn't put the thought in someone's head or anything like that. But I want to throw that out there and speak to it because it's a concern that many people have when they read some kind of literature or the handout that the pharmacist or the doctor gives when they say, hey, we're going to start you on some Effexor. And they see this black box warning and it terrifies them about what might happen. So I just wanted to speak to that briefly. Again, I won't go into too much detail. I talked about these MAOIs and TCAs briefly. That is the drugs we would use to address the crocodiles there in the river, that synaptic cleft, okay? Some of you may have heard of some of these medications. A lot of them are old. And I also want to throw out, they are effective. We think about the MAOI, that is the MAO inhibitors. We think about the tricyclic antidepressants, the TCAs. Some of you may have heard of amitriptyline. There are side effects often with drugs that we can use to our benefit. Think about a drug that is sedating. Well, we may not use it for depression, but we might use a lower dose to help someone with insomnia. Okay? These medications, again, are effective, but usually are not well tolerated to the point where the dose needed to treat depression, they can't tolerate. Lower doses, perhaps we can use it for another benefit. Again, they can make people sleepy. Orthostasis, is that thing where, you drop your pen and you bend over to pick it up and you stand up and now you're lightheaded. It's literally because blood rushed out of your head and, you're not getting enough oxygen in your brain. And some people might pass out because of it. We think about orthostasis. They are anticholinergic. That word, I want you to think Benadryl. Some of the side effects associated with Benadryl. Sedation, dry mouth, dry eye, I'm thirsty. In more severe situations, urinary retention, they can't go to the bathroom. So these are also side effects of the drug. Dietary restriction for the MAOIs, certain foods, certain drugs that you cannot take necessarily while you're on the MAO. The SSRIs are very familiar to us. We've all heard of Prozac, right? Paxil, Lexapro, Celexa. This one, this Vibrid, or vilazodone has some mixed activity in its mechanism. It's like mostly like an SSRI, but maybe not entirely like them. Again, as an antidepressant, it's very effective, but it may not fully fall into that SSRI category. We look at the SNRIs. So we know the benefit of giving an SSRI as far as the impact of preventing serotonin reuptake, that is, allowing it to hang out in that receptor a bit longer. But if a patient isn't as responsive to that, it's like my mood's a little better, but I'm still lacking some energy. We can also benefit with reducing that effect of norepinephrine reuptake. So think about norepinephrine, think about epinephrine, right? Which is adrenaline. So if I give a medication that allows adrenaline or noradrenaline a longer amount of time to work in the body, I might be able to boost some of the energy aspect that's been lacking in depression, okay? Most of these medications are available as generics, okay? That is, the patent expired on the brand name, Prestige, and when the patent expires, well, now anybody can make it. There's not a sole copyright for this drug. Now anybody can make it. And when they make it, they have to demonstrate to the FDA that this drug matches all the pharmacokinetic parameters of the brand name. Remember we talked about what is the body doing to the drug? That is how it's absorbed, how it's distributed, how it's metabolized and excreted, that those all match. And basically, they have the recipe. So if the brand name manufacturer has made it, they've demonstrated all the math to the FDA, and they've approved it for brand name use for approximately 15 years. Once that patent expires, everyone else has the recipe, right? They can make the same exact thing. There are some very minor differences in the math, but we would say they are not clinically significant, okay? I mean, you may have your own recipe for meatloaf, and you put the same exact stuff in it each time, but for whatever reason, it comes out just a little different. You put the same amount of ground beef, the same amount of onions, and etc., cooked it at the same temperature, cooked it for the same time, and it comes out slightly different. But at the end of the day, it still tastes the same. Now, I'm not saying that your prescription medications are the same as a meatloaf situation, but you get the idea there. Okay? I mentioned this earlier, SSRIs, SNRIs, the mechanism of action is to increase, so please forgive some of my abbreviations. This is all medical nerd talk. 5-HT is the abbreviation we use for serotonin. Norepinephrine is this one right here, okay? We use it for depression, anxiety, OCD, PTSD. Remember I said it early in the beginning, we use a lot of antidepressants for mixed bags of things. Side effects, serotonin syndrome. You take too much, it could cause very severe cardiac problems, okay? It might cause a muscle tension where they are locked in, okay? It could even resemble a seizure, but this is emergent. So, when someone reaches that display level of activity, a change in mental status, etc., this is when they go to the ER. Sexual dysfunction. We're a bunch of prudes in America, and we don't talk about this very much. And so some people might be reluctant to bring it up to their psychiatrist or their prescriber. These aren't just psychiatrists prescribing Lexapro and Effexor. These are primary care doctors because they have been trained, as we said earlier, to assess. And that's why we're seeing more people on it appropriately. But sometimes doctors or patients don't come to their doctor and talk about this. Sexual dysfunction, including like erectile dysfunction, changes in libido, etc. And it's problematic. If there's anything about these medications where the patient says, I don't think I want to take that anymore, well, all of a sudden their mood problems return. This happens for not sexual dysfunction, but when a patient is going out without their meds, then obviously symptoms can repeat. Withdrawal. I use that word cautiously. This is not withdrawal in the same thought as alcohol, Xanax, heroin, those pain pills. We usually refer to this more medically as a discontinuation syndrome. So, but I still call it withdrawal for the common folk, right? So the idea being, if a patient has been on some of these medications for months, few years, and decided one day, without talking to their doctor, you know what, I think I'm good, I'm going to stop taking it. And they just stop taking it. They may have very severe flu-like symptoms for a number of days that just make them feel awful. So that's a potential adverse effect. The idea of drug interactions, what drugs should you be cautious of taking with some of these SSRIs? Other serotonin meds, because then we look at serotonin syndrome. Like I said, cost minimal. Most are all available generic, so they're widely available and covered by insurance. We have some miscellaneous drugs that don't work exactly like those other ones. They're not necessarily that whole gazelle meets crocodile situation. Bupropion is one. Wellbutrin. Bupropion works primarily on dopamine and norepinephrine. So dopamine having a more unique mechanism of action can be combined with drugs like Lexapro or Prestige, etc. We think about mirtazapine, very effective and frankly works faster than some of the other medications like the SSRIs and SNRIs, but maybe not tolerated as well because patients might feel sleepy, they might gain weight. But guess what? This might be the ideal medication for a patient with insomnia, severe weight loss because they've been so depressed, they just couldn't eat for months or time for quite some time. Trazodone, similarly, very effective, but might make people sleepy. So primarily, we see trazodone used for insomnia at lower doses. Schizophrenia, again, I won't speak to quite so much. This is quite a topic, just like depression. We think about 1%. That means 1 out of 100 people. Think about that across the broadness of the United States or across the world. That is a lot of people. Schizophrenia, I think, for those who have not had maybe personal experience with, seeing it, this is not the same as dissociative identity disorder or multiple personality. I think that was a, misunderstanding by a lot of people. One point in time, schizophrenia is not multiple personalities. We say it's characterized by psychosis, right? A change in perception. That is hallucinations, be it auditory in your ears, visual, I'm seeing things. Some people feel things, tactile, smell things differently. So we think about psychosis. That can include also perhaps delusion, paranoia, the idea people are after me, someone's watching me. We also talk about not only these positive symptoms, right? We think about things that are removed, perhaps in the sense of something less than what a normal person might have. This might be a mood disorder, a component. They may have hallucinations or maybe not. They may have changes in perception, changes in language and thought process, but they're very depressed at the same time and maybe even suicidal. We think about disorganized thought and speech. In some situations where people will speak in rhyme. We'll talk about clanging, where they will make have you ever heard the term onomatopoeia? It's one of my favorite words in the English language. It's words like bang, boom. It's a word to depict a sound. And some patients may speak in those type of situations. Catatonia is where a patient looks wide awake, but they are maybe non-responsive. We might use things like for testing, we might take their arm and elevate it, and it just hangs there in midair. They just leave it. It's catatonia. Some of the problems with this is not only the fact they're not speaking, they're not eating or drinking. So we might see things like not only weight loss, but acute kidney failure because they haven't had anything to drink for 4 days. We think about how schizophrenia works through the brain through different tracts, mesolimbic, nigrostriatal, and mesocortical. These are dopamine tracts in the brain, and I forgot tubero-infundibulum. It's important because these dopamine tracts are also related to Parkinson's disorder. Some of these medications you may have heard either through personal exposure or, on TV or in a movie. You may have heard of Thorazine, used in a psych hospital. Haldol is very familiar to some of our patients, or even Prolixin. The newer agents, we talk about the first generation are typicals. The second generation are the atypical. They have a very similar effect on dopamine, but the atypicals may have some effect, not may, they do have an effect also on serotonin receptors. So you may have used these yourselves or family members or seen the commercials for Abilify or Seroquel or Saffris or Latuda. And again, all of these are available generic. Well, paliperidone, not available generic with some of the injectable forms. So I mentioned this is blockade. Again, the fancy language in our medical world, 5-HT is serotonin, DA is dopamine. They're used for schizophrenia, some cases for depression, bipolar disorder. We might use them PRN or as needed for agitation, maybe even anxiety. Adverse drug effects, side effects, could be things like sedation, could be things like potentially a seizure. We talk about NMS, neuroleptic malignant syndrome. I kind of briefly described serotonin syndrome earlier. Neuroleptic malignant syndrome looks very familiar. We talk about muscle rigidity, perhaps an elevated temperature, a change in mental status. That's emergent. Okay, that requires a trip to the hospital ASAP. Tardive dyskinesia is also not uncommon. This is for patients you may have seen with tremor. Okay, remember I talked about the dopamine tracts and how they, also are associated with, say, Parkinson's disorder. These medications with chronic long-term use have a high probability to cause tremor that resembles Parkinson's disease. In fact, we call it Parkinson-like syndrome or Parkinsonian syndrome. We think about cardiac effects that we might track through an EKG. So, you plug on those leads. Oftentimes, a doctor starting these medications and then maybe once a year is going to take an EKG to make sure it's not affecting cardiac rhythm. CBC, so we think about white blood cells. These are labs also that the doctors are monitoring because they can cause a drop in white blood cells, specifically clozapine, which means, and I'm being very a little facetious here, but through lab work, it could potentially mimic AIDS. So the risk of this and dropping down your white blood count is a higher risk of infection, which is why doctors are monitoring that. It doesn't happen to everybody. In fact, most people are taking these medications with not a single one of these side effects. Maybe sedation, maybe some weight gain. Most people are not going to see any change whatsoever in their white blood cell. Most people, in fact, by far, most people will never experience NMS or a seizure or a change in their heart rhythm. But it's something we know can happen. Okay? We talk about, again, first generation versus second, that is the typicals versus the atypicals. The older ones, Thorazine, Haldol, have a higher likelihood to cause things like those tremors, more so than the second generation. The second generation has a higher likelihood of causing weight gain or diabetes, belly fat, higher cholesterol. So patients are sometimes left wondering, which one do I want to take? Which side effects could be worse? It's like I might risk tremors as long as I can stay in the same jeans I've worn for the past 10 years. That's, body image. We have to take that into account. It can be simple, like, are you kidding me? Do you not want to be in the hospital? Who cares if you gain, some weight? Some patients, 10 pounds is a lot. It's very significant to them. Some patients take drugs like clozapine or Seroquel or Zyprexa, and they gain, and I'm not kidding, they might gain 100 pounds. They're not just eating more. We're talking about a significant change in hormonal function by impacting some of these dopamine receptors. Because they not only are impacting dopamine in the body and maybe serotonin, there is in some situations a histamine effect. So you've heard of antihistamines, right? Benadryl, Claritin, Zyrtec, etc. Higher effect on histamine receptors, especially when taken on a daily basis like these meds are what we attribute to things like some of that weight gain. We also know that some of these medications and antihistamines cause some sedation. Would you believe that there are some people that associate feeling sleepy if I take a pill with the same thing as being high? And people think like that. Some people intentionally abuse Seroquel or Zyprexa when they don't have schizophrenia or bipolar disorder. They take it on purpose because they think it's getting them high. And I will let you take from that what you will, but know that some of these medications are abused. They're not addictive. Okay, they're not going to go into withdrawals if they stop taking it and things like that, but they are abused. I won't go into the Katie trial other than to say that none of these medications treat psychosis better than another. They are all, we would say, they are not, there's not one that's inferior to another. I'm trying to use the exact language that the researchers use. They're non-inferior. However, that is not to say some patients tolerate one medication better than another. I can't give, Robin the same med as I might to Eileen and expect them to work the same, even at the same dose. Or even Eileen gets 100 milligrams while Robin gets 10. It may not treat their disease state the same. Eileen might require a different medication. George might require that one plus another one, okay? We might give one to Darla for months, only to find out, you know what, it's never working. She's having side effects, and guess what? We've misdiagnosed her. That's why this medication wasn't beneficial at all. But the Katie trial looked at trying to prove that the newer ones were better than the old ones, and it was not the case. Ultimately, the biggest difference was in side effects. Bipolar, again, we've covered depression and depressed mood. It's the manic piece. We think about the globe, right? North Pole, South Pole. Bipolar 1 is they are reaching the North Pole in mania. Okay, we are not talking just impulsivity, but decreased need for sleep, perhaps psychosis. That's all that's needed for a bipolar 1 disorder or any bipolar diagnosis is a manic episode at some point. But we also have to qualify that with a diagnosis of major depressive disorder. So they are cycling between the two with varying degrees of time in between. Maybe they don't hit the full North Pole, right? Maybe they hit somewhere around Canada, okay? That would be bipolar 2. They have hypomania, not full North Pole, but still South Pole major depressive disorder. Maybe they hit Canada and not full South Pole. Maybe they're hitting like lower Africa somewhere, right? We call that cyclothymia. Not full north, not full south, somewhere in between, but not in the sweet spot of the equator. Did you guys all like my globe display there? So let me get some water here. All right. Classically, we think about an algorithm. Think of that flow chart. If this, then this. If a diagnosis of bipolar disorder, the classical algorithm, the classical flow chart, if then was, give them an antipsychotic, specifically a second generation antipsychotic, with a mood stabilizer, such as lithium or Depakote. But we know that all people are not created equally, and a lot of people do not get that combination for whatever reason. They can't tolerate it. They do just fine on Latuda without lithium and Depakote, right? We might give some people an antipsychotic with some carbamazepine, some Tegretol. There is no one size fits all for any of these behavioral health disturbances and diagnoses when it comes to medication. We may have to address acute, that is like more emergent or urgent symptom flare-ups versus, prevention of a return of a manic episode or depressive state. So again, a patient who has better self-awareness, know some warning signs when they are shifting into a manic state. Or maybe they don't. And truthfully, maybe they do know it and they like it because it's better than feeling depressed and suicidal. And I'm not getting my work done and I don't feel like engaging with people around me. But when I start creeping up into mania, feel better, right? Some people intentionally stop their medications because they feel flat. They don't feel great. Sometimes they like that feeling of the energy that mania brings. And that's a conversation they need to have with their doctor, because if they don't like, remember what I said earlier, there's any reason they think when they're taking that pill in their hand, I don't know if I want to take this today anymore. And that's a problem. There needs to be a conversation with their prescriber. Mood stabilizers, lithium, I talked about Depakote and carbamazepine. There's a couple others we use like Lamictal and Trileptal. I'll be honest, I don't think there's really great research, or that is results showing effectiveness of Trileptal. But I do know that there's a lot of prescribers that still use it because it's kind of a kissing cousin to Tegretol. But I think ultimately it's probably not a great treatment for bipolar disorder. Lithium, it's on that periodic table. I know you all memorized it probably in 6th grade somewhere in middle school. You know, you got sodium, oxygen, neon, you know, you got that left side, the right side, all the boxes, the weights, the molecules, and how the electrons spin around. Lithium's on there. It is a naturally occurring substance. Chemically, it's a salt. So don't anyone take their lithium tablets or capsule and try to sprinkle it on some French fries. It is not that kind of salt. But it works similarly in the body going through the kidneys, okay? This is one of those, I want you to think back to that curve, that graph I showed in the beginning, and a therapeutic range. Some medications have a pretty broad therapeutic range. I can give you 100 milligrams of Seroquel. I can give you 1,000 milligrams of Seroquel, and you might still feel okay without side effects, right? Lithium is one of those where that window is much more narrow. I can give you a little bit or just a little bit more, but if I give you more than this one, you could have a seizure. So this is one of those drugs where we draw blood levels because the therapeutic range is more narrow, okay? We think about thirst because, like I said, it's a chemical salt that affects sodium and fluid balance in the body, so some people feel thirsty. Tremor is not uncommon. Tremor potentially is a warning sign that they're reaching that higher level in the therapeutic range. Seizure as well. Anticonvulsants. We use these medications like, again, Depakote, carbamazepine, Trileptal. These are all anticonvulsants. The way they impact nerve signaling may reduce that transition likelihood into a manic episode. GABA is one of the chemical channels involved. Some of you may have heard of gabapentin. You may have heard of drugs like benzodiazepines, like Xanax, Valium, Klonopin, Ativan. They also all work on GABA. These are drugs where we might look at some lab work, not only white blood cell, but red blood cells. We might look at pancreatic function, your liver function. These are medications that we monitor. Anxiety. It's not just being nervous. We talk about anxiety disorders to the extreme where it is impacting daily life. That might require a medication intervention. It more likely could benefit from psychotherapy or some kind of behavioral therapy. Sometimes medications are really a saving grace for someone with an anxiety disorder. Anxiety disorders can also include obsessive compulsive disorder. PTSD kind of dips its toe into anxiety disorder, but it kind of is also classified as its own sort of thing. But it's crippling for many people. In the moment for a panic disorder, we're going to use very likely something like hydroxyzine or one of those benzodiazepines, like I mentioned, like Xanax or Valium. For a day-to-day chronic anxiety disorder, we're going to use an SSRI like Celexa or Zoloft. Here's those benzodiazepines I mentioned earlier. Again, the brand names are in the parentheses, generic here to the left. The thing with benzodiazepines, they work really well. They are virtually impossible to overdose them, okay? So people take a little, what if I take a little bit more? You know, what's that going to do for me? The risk is addiction. They are very addictive, especially chronic use. The other risk is prolonged use and then abrupt discontinuation of the drug. I mentioned how anticonvulsants work on that GABA channel in the body. So the benzodiazepine, it has a calming effect. Think about how nerves are talking to one another like electrical signals down a electrical cord. If I can decrease the force at which it's traveling, not necessarily the speed, but how hard and forcefully it travels across nerves, it can also translate to a calming effect. While we use them for seizure disorders. But if I take that drug away very suddenly, it might actually trigger a seizure. Alcohol is a chemical that also works on the GABA channel, which is why some of you who are familiar with alcoholism or alcohol withdrawal know that some patients have all of a sudden elevated activity of anxiety, their heart rate increases, and could have a withdrawal seizure. So the risk of these, the warnings about benzodiazepine is not so much about overdose, it's the addictive quality and the risk of withdrawal. Okay? They are sedating. I mentioned this piece and the high abuse potential. Understand that you or your family members that are on these drugs, these are considered controlled substances. There are limitations on how frequently doctors can prescribe it. They're going to look the patient up in the database. There's limitations on how frequently the pharmacist can refill it. So there's some of that stuff that goes on with it. Okay? Other medications available that are not addictive in the sense of like having a withdrawal syndrome would be Buspar or Buspirone. Some people might complain that it's not as effective because it's working slower. I can tell you from my patient population that I work with now, so many times I'm reading a med list and a patient's on Buspar taking it as needed. It doesn't work like, these benzos where they just take it for a breakthrough anxiety attack. Buspar needs to be taken every single day, and however the doctor has prescribed it. 5 milligrams twice a day, 15 milligrams 3 times a day is another dosage range, but it is not an as-needed drug. Some people feel like, well, I tried to take it for my anxiety attack because my doctor's a meanie and he canceled my Xanax and put me on this. Well, I had an anxiety attack and it didn't work. Well, it doesn't work like Xanax. So we have to make sure we're counseling and talking to our loved one. You got to take this every day. Antihistamines, again, think about like Benadryl, right? Hydroxyzine is also a very strong antihistamine that isn't as sedating. So it may have the calming effect without making them as sleepy. I was asked, because I haven't really added this before in my slides, but I was asked to add this in. The idea of dissociative identity disorder. Let me throw in again, I'm a pharmacist. I am not a diagnostician. I am not a medical doctor. I'm not a physician. I'm not a psychiatric nurse practitioner. I am not allowed to prescribe. And part of my scope of practice is that I'm not permitted to diagnose. Okay? I can't assess you and give you a diagnosis. Now, I know a little about a lot of things. I know a lot about a couple of things. I happen to know a lot about psychiatry. This is still one of the more puzzling things that I've ever come across in my training and practice, is the idea of dissociative identity disorder. It's not necessarily hard to diagnose. In the medical world, we talk about a differential diagnosis. Don comes into the clinic and his stomach hurts. Every single one of you in this Brady Bunch screen right now could give me some reason why Don's stomach might hurt. Well, it was the oysters he left sitting in the car after he got them from the restaurant and he ate them 12 hours later. Maybe that was it, right? Maybe he took one of these medications that causes stomach upset. Maybe Don has stomach cancer, right? There's any number of things that we need to rule out before we just give a medication, right? Think about constipation, diarrhea, anything that can happen with that stomach. The doctor is going to ask questions, right? Maybe do lab work, maybe do an x-ray. All these things will be looked at before they say, okay, my best guess. And ultimately, that's what we're doing with psychiatry is a best guess based on the symptoms you told me, based on some of the lab work, based on some of the things that I don't think it is, right? I'm pretty sure maybe Don's not pregnant. But maybe we did a pregnancy test, and ruled that out, just in case. So, I mean, there's some things that we have a better inclination towards versus another. Oh, you haven't gone to the bathroom in 3 weeks. All right, let's give you a stool softener and then see what happens. Okay. Same thing goes in psychiatry. It's an educated guess based on some of the answers and responses you've provided. In many situations, the patient themselves can't provide that history or the answers to that question. They're in a psychotic state. They're paranoid. If I give you this information, you're going to send me overseas, and I know you're working for Bill Gates, and we know what he does with everybody. So, I mean, sometimes it requires outside sources of information, family members, the police, that kind of situation. Dissociative identity is a lot of times based on what I'm ruling out, okay? This is a description that was provided in a diagnostic manual, a disruption in consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. That's complicated, right? This is also more commonly known as multiple personality disorder. And I don't want you to think about, those extreme scenarios that you've seen in the movies. I forget the one where the guy ends up like turning into a monster. Sorry for the spoiler alert, whatever movie that was. But people that, shift. Right now they're a 12-year-old boy, and now they're a 45-year-old woman. It's not always like that. Sometimes it has some similarities to those things you might see in the movie. Prevalence. I want to mention this again. I'm saying greater than 1% because that was what was in the literature. It's saying perhaps 1.3 to 1.5. Remember the schizophrenia number I gave earlier? 1 out of 100 people. Now broaden that to the entire United States. That's a lot of people. There are very likely more people with dissociative identity disorder. Okay. And again, I don't want you to picture everybody walking around with 40 different personalities that go in their head that shift from, one moment to the other. It's this complexity of description I've given in the beginning. We look at ruling out what else might they be dealing with that's not dissociative identity disorder. Substance use disorder, right? Drugs and alcohol, things like that. Very commonly, we see what's called a co-occurring disorder. They don't just have DID. They also have PTSD. So co-occurring is a term we use frequently in behavioral health. More commonly, we might see it where a patient has a substance use disorder and another psychiatric diagnosis. They're alcoholic and they have depression, right? We're not going to get into a chicken or the egg scenario right now. They hear voices constantly. And you know what they like to do? Swallow opiate pain pills so they can just go to sleep and drown out the voice. Co-occurring. That is things happening at the same time. We're using co-occurring here, not really in that definition specifically with substance use, but DID, very commonly with PTSD. Patient has experienced such level of trauma at some point in their lifetime that they have created perhaps a way to disassociate and not think about that trauma. They may have amnesia of some type. We think about people who all of a sudden through therapy and et cetera are recovering memories from, who knows when. Is it already 8 o'clock, by the way, Don?
It's coming up on it. I think you were. I wanted you to get through DID, but you talked through the chat message I sent you a little bit.
Okay. With the idea of what are therapies for it, psychotherapy is really going to be the gold standard. There aren't meds to treat DID like we think about with depression, anxiety, et cetera. We might use it for symptomatic relief, perhaps in anxiety or insomnia. But we think about the idea of PTSD, et cetera. That's going to be more for symptomatic piece. I want to skip this and kind of see if there's anything really. The idea that I want to kind of hammer in is that some of these drugs will need to be monitored lab work. Certain foods and drugs just don't go together with psych meds. And everything a patient is doing as part of their lifestyle, be it alcohol, smoking cigarettes, other medications. That's important for prescribers to know. Barriers to adherence, we know cost. Look at generic medication, patient assistance, from the drug manufacturer, perhaps sampling. I don't want cost to be an issue. They need to let their provider know it's something we deal with constantly. I can't afford my meds. And it's not just this one, it's the fact that I'm on 12 medications, and they all have maybe varying copay. Side effects. If it makes you feel worse or just even a different kind of worse, and the patient says, I don't think I want to take this, that's the problem. Again, the idea you're not cured, it's going to maybe remit symptoms and reduce symptoms. That doesn't mean you can stop taking the medication. Again, some patients may have continuing symptoms with treatment. They're like, well, I'm still hearing voices. Yeah, but do you know they're not real? That's kind of the distinction there. You may forever hear voices, but lower, they're not as scary. The idea of pill burden. We think about a prescribing cascade where I give you a drug, it causes a side effect. So let's give you drug number 2, treat that side effect. Well, drug number 2 has its side effect. Next thing you know, you're on 8 medications. Well, what if we go back to the beginning and adjust drug number 1, and now maybe we're reducing how many pills a patient's taking a day? The idea of stigma, again, a lot of people. Think about how broad the population is, not only with schizophrenia and perhaps DID, but even more people looking at mood disorders of varying types. And it just takes, knowledge and education to reach out and get help. If I had an extra second, I just wanted to add on one thing based on request, was the idea of pharmacogenomics or genetic testing. It was asked and presented the last time. There's a company called GeneSight that you guys can look up. It's GeneSight, and I can put it, in the email to Don. It's looking at the enzymes that break down many of these psychotropic medications. And if you are of a genetic predisposition to eat the drug faster, I'm not talking about you put it in your mouth and chewed it faster. If you have a genetic makeup that breaks down the drug faster, think about that curve, it wears off sooner, okay? You may have a disposition to the point where that drug will never work for you to treat your mood symptoms. And so we're seeing, this great phenomenon of medical breakthrough where we're seeing changes. Some of these drugs have been out for a while. Some patients are on therapy for a while, and they're just thinking, I guess this is as good as it gets. I feel a little bit better. And the doctor doesn't change the drug, doesn't go up on the dose. Maybe they go up on the dose and it's still not helping. And the patient just feels stuck. I'm telling them it's not helping. They went up on the dose. I don't really feel better. And I feel like I'm being a pain in the neck if I bring it up to the doctor again. So they just live like that, miserable. And the people around them are miserable too because the patient's miserable. Like we said in the beginning, they're irritating. They kind of have maybe other symptoms going on, but sometimes we see that at a genetic level, at an enzymatic level in the body, some of the drugs they've been taking may never, ever work. So there is a role in therapy for some of these psychiatric medications to get genetic testing done, and it's available out there. It's fascinating, and many insurance companies are paying for it. I think some plans like GeneSight may actually work with the patient, like patient assistance for medication, to help it be more affordable if your insurance company has a higher copay. So I did want to speak to that there is a role for it. You may find that the doctor is reluctant because maybe they're just not up to date on newer research. I would suggest, maybe paying for it out of pocket or having your loved ones do it. Again, with some of these companies, they may have a payment plan or something, but it may be worthwhile. You take that paperwork to the doctor and you see, now look at this. This was my lab work. What does this mean to you? The doctor might be impressed, and you might be the first one who's kind of gone through with it. But I did want to speak to that before we ended tonight.
Joseph?
Yes.
Was that just, and hi, by the way.
Hi.
Was that just for psychiatric medications, that particular testing?
Yes, it appeared so. When I went to that GeneSight website, it appeared to be specific for psychiatric meds, but I will say they're doing it, I think, under that umbrella and maybe trying to cater to that population of patient. Nonetheless, it's identifying enzymes in their report that are potentially pertinent to other medications that are used for other things.
Okay.
But I think they are gearing their presentation towards patients on psychotropic medication.
Yeah. So,
Oh, do we have, we do not have any questions in the chat. Does anyone have
Okay.
any quick questions? It is at 8 o'clock. If you do need to leave, remember that we will have this on our YouTube channel, the audio, but I want to give you a chance to ask some questions of Dr. Pandit real quick, if you have any.
the only thing I'm going to ask Dr. Pandit too is very briefly, because we are getting on time here, is the long-acting injectables.
Sure, I did skip through that pretty quickly. Again, we discussed the idea of patients and compliance or adherence, perhaps because of side effects, or they don't like taking pills, or they feel better and historically take them kind of when they want to. And we know from the research that's out there, remember I showed you that curve. If they're falling below that dotted line, the drug's not doing anything. We know from research and relapse rates, readmissions to hospitals, especially in psychotic disorders and bipolar, these are medications that by current medical standards, these are medications the patient will likely be on for the rest of their lives, okay? I'm type 1 diabetic. I take insulin every day. Unless one of you wants to donate your pancreas to me, this is something I got to take every day. I have to be adherent, even though my lab work looks good. In a case of some of these medications, if a patient is either unwilling to take their oral medication consistently, or they just request, like, doctor, I hate taking pills. Sometimes I forget to take it. Do you have any recommendations on helping me remember? The doctor may say, yeah, there's long-acting injections out there. These are specific currently only for a few of those antipsychotics. Abilify, Risperdal, Invega is another. So these are medications that have and Haldol and Prolix, and the first generations are available, a range anywhere from a shot every 2 weeks to every 3 months. We're looking at with some of these medications. There may be a brief overlap where the patient gets their first couple of shots and still takes the pills, and then they can come off the pills, eventually, and just get the shot. But that is an excellent option for adherence. Again, the patient's unwilling to take it, or patients are like, you got something easier because I hate taking it. But those are options available.
Thank
Joseph,
you. And I was going to say, we do understand that TennCare is just recently agreed to cover some of those.
I was not aware of that.
Yeah.
And it's been a bit cost prohibitive in some scenarios. Some patients were able to get it covered, like, at their doctor's office. Sometimes it's a situation where it gets shipped to the Walgreens, the patient picks it up from there because it goes under maybe a pharmacy benefit, and then they take the box to the doctor's office. But that's wonderful, because I think too often insurance companies or the people with the checkbooks are like, they feel like it's cheaper to cover on the back end and treat the problem when it actually arises, rather than preventative measures like just cover the shot. You guys are paying out of pocket for hospital admissions and the morbidity and the mortality rates from patients. What if we try to pay for measures that prevent that from happening, like injections? So that's wonderful news. Don, I think you had a question.
Joseph, we've got a question in the chat. Are Elavil, Cymbalta, and Buspar all serotonins?
Yes and no. So they will have different, I don't want to say potency, different effects on how much they're impacting serotonin. Those three medications, although different mechanisms, can impact serotonin levels. And I talked about serotonin syndrome, but that is a very common combination of medication that can be used very safely.
Thank you. Do we have any other one or two more questions before we wrap up? I'll take that as Joseph. You've been very thorough tonight. We always appreciate you coming out. As I mentioned earlier, Joseph will be sending me the PowerPoint presentation that I'll be sending in an email to all the registrants tonight. I will also be loading the audio version of this education session to our YouTube channel. I will send out a email to our listserv when that is active. We also have 23 other education sessions on our YouTube channel, so a wealth of information. But I'd like to ask all of you to join me in thanking Dr. Pandit for taking his time and being very thorough tonight. We always appreciate his time and his effort. He's a good friend of NAMI and is helping our members understand a lot of the tricky parts of medications. So we appreciate that.
Thank you all for coming tonight. And I appreciate you, Don and Robin, and I guess Eileen also at NAMI. So you've all been fantastic. And I'm sorry if I missed someone else who's also joined with the NAMI.
We've got George and Karen who are also.
Yeah, I'm sorry, George and Karen. I've got this lap. I'm sorry. My apologies. Oh, Karen. I'm sorry. I forgot Karen. Right?
Yeah, Karen.
Oh no, my apologies. I won't let that one down. But yeah, thank you guys so much for having me.
Thank you, Joseph.
We always appreciate you. Thank you so much.
You're welcome.